questions for Dr. O'Brien or Dr. Ritchie? One or two brief questions in the interest of time.
I often wonder whether in ALL adults, the only improvement has really been in the identification of Philadelphia positive ALL as well as the Burkitt's and the treatment changes in the treatment. Whereas for the rest, I wonder whether there's been any improvement. Now, the timing for the transplant in the high-risk ALL, say in a TALL who has more than 100,000, and in our Jamal protocol, we induce, then we intensify, then we transplant. But I've had occasions whereby even when the MRD is negative and we transplant, they relapse within 3 months. Should we give more chemotherapy before we transplant? Should we try to push the depth as low as possible? Is there utility of that?
So I think to answer your first question, which I think was more of a comment than a question, but I think there has been substantial improvements as overall in adult ALL, although we probably shouldn't be too greedy about how big an improvement we might expect to see. And certainly identifying subgroups as they have done at MD Anderson with the CD20 positivity in Burkitt's and in precursor ALL, and I think there has been with the sequential evolution of multi-agent chemotherapy protocols as really pioneered by the German groups. There have been improvement in TALL as well. But to answer your other question, I think that I'm primarily a transplanter, as you know, and I'm very concerned about patients who are exposed to high levels of prior therapy, even in the first remission, coming to transplant. And as with the UK ALL group when they were running the 12 study, they originally had allogeneic transplantation in after the high-dose methotrexate block, but the amounts of cumulative mucositis, sepsis, and poor tolerance, including deaths, during allogeneic transplant meant that they actually modified the protocol to having patients being preserved away from that high-dose methotrexate. So I think, your experience reflects all our experiences, is that there are patients who are in remission, appear to be MRD negative, are having the best control therapy in the form of allogeneic transplantation, but despite all our best efforts, still relapse, and that's the nature of adult ALL.
Just quickly, is auto transplant worth a revisit, especially in the Philadelphia positive ALLs who don't have a sibling match and who is now in molecular remission following your Gleevec and Hyper-CVAC?
My personal view is no, but that's a personal view.
No, yeah, I would agree.
Steve?
Well, what's the percentage of Philadelphia positive ALLs that also express CD20?
It's about 30 to 40%, Steve.
And so in that subset, do you include rituximab?
Yeah, so now we do. In the original trial that I showed you, we did not, probably because we were doing the CD20 concomitantly, and so that hadn't, we didn't know if that was going to make a difference. But would I do it now? For sure. So but I don't have any data to tell you.
So the algorithm you showed, you think that'll be modified in the future?
Yes, sir.
If you're positive ALL, is molecular remission alone is a criteria for not to go for allogeneic transplant if they don't have a sibling?
So is your question that if they achieve a
molecular
remission that you would not transplant them? I mean, Susan has far more experience with respect to pH positive ALL than I do. My very simplistic view is that TKIs allow us to get patients into a better remission in better state so that they can actually be transplanted more safely. And I still think that it's a brave hematologist who avoids allogeneic transplantation of pH positive ALL unless there's reason to avoid it, such as advanced stage, whatever that might be, or comorbidities.
This is one of the biggest questions, I think, in ALL, not just for pH positive, but for anything. I think one of the issues is that not all MRD is the same, and it probably depends on the regimen. So for example, with hyper-CVAD and imatinib or dasatinib, in our hands, the PCR, which is a beautiful correlate in CML, doesn't work very well. It doesn't correlate. And for the six-color flow actually correlates better, although not perfectly. So I think the issue with talking about using MRD is that one doesn't know for a particular regimen, unless one looks at the data, what does correlate with outcome. And it may not be the same for different regimens. So I think that's one of the biggest problems, is we talk about it like it's a universal phenomenon when there's different ways to measure it, as you saw from David, and then it may also depend on the intensity of the regimen. So that's a very hard question to answer. My simple answer to you would be, barring a lot of comorbidities or things, I probably still would transplant that patient, but that is a topic that comes up and gets discussed extensively all the time. I don't think there's a right or wrong answer.
Can I ask a very simplistic question? When we are inducing adult ALLs, we are having a bewildering array of choices. One is UKLL12, one is BFM, one is hyper-CVAD. Which, according to the panel, is the best mode of induction in adult ALL?
So interestingly, there's a lot of data that you've probably seen from many different countries suggesting that in young adults and adolescents, treatment on pediatric regimens is much more effective than the same age group being treated on adult regimens. Now, if you look at the reason for that, that may be multifactorial, including that someone who's 18 and lives on their own may not be having the same compliance as an 18-year-old brought in by their parents. So there's a lot of issues. But one thing you notice is that, in general, pediatric regimens for ALL have a lot more non-myelosuppressive chemotherapy. So lots more vincristine, asparaginase, which is a very difficult drug to give to older patients. And those, if you look at the regimens, they are much more intensive dosing for those. Interestingly, so we are now doing augmented BFM for patients up to the age of 30. And we are comparing that in that same age group to our historical control with hyper-CVAD, which doesn't have any asparaginase, but is a very dose-intensive regimen, as you well know. And so far, with limited follow-up on the augmented BFM, but with about 100 patients, just not really long follow-up, it doesn't really look much different than the hyper-CVAD, and that may be because hyper-CVAD is such a dose-intensive regimen. But I think the augmented BFM is, and in terms of ease, you get more myelosuppression with hyper-CVAD, but in terms of transaminase elevation, bilirubin, DVTs, all of that, I find a BFM a much harder regimen to give.
So your vote is for hyper-CVAD?
Well, of course.
Okay, last question.
But I think augmented BFM is an excellent regimen. It's just hard to give to older people.
Last question.
Yeah, Satya Yadav from India. Just there is a current children's oncology group data which has come on pH positive ALL, where they have given imatinib plus standard leukemia treatment, and they have stopped everything at the standard 2 years, what we do in pediatric leukemias without transplant. And they've shown survival rates of around 75 to 80% at 3 years at 3 years follow-up, event-free survival. So there is some data that maybe we need longer follow-up, that how many relapse. But without allo transplant in pH positive ALL in pediatric, they are doing it without transplant, that one study has shown. So my question was, this was comment, and my question was role of dasatinib in pH positive ALL once they are in molecular remission, but if it starts going up on follow-up, the MRD is increasing, should we transplant them straight away, or should we try dasatinib first with chemotherapy?
So sorry, they're on imatinib and their MRD
they were doing well,
increasing.
but now MRD is increasing slowly on imatinib.
Well, with all the caveats of interpreting the MRD, yes, I would switch them over, but I probably would transplant them. And just to comment on your pediatric, it's interesting because you would think that pediatric pH positive in adult would be, aside from perhaps toxicity from chemo, would really be similar diseases because the molecular driver is the same. But interestingly, they're not. Historically, even pre-imatinib, the cure rate, even without transplant in pediatric pH-positive disease, was about 25%. It wasn't anything close to that in adults. And there was some data from St. Jude's that suggested that the white count, the presenting white count was a determinant. So lower white count had a higher chance. In adults, that data could never be reproduced. So interestingly, even with the same cytogenetic abnormality, at least historically, adults appear to do much worse, and not just because of toxicity, but much higher relapse rates. I don't know why that is, unless there's secondary abnormalities that are accounting for that.
Okay, I want to thank everyone for a wonderful, exciting session, and I think we'll turn the podium over to the next chairs.